You know, AML and ALL are devastating, life-changing diagnoses at any age. Many patients are helped, some cured by current therapies, but there are also some dark corners of the leukemia world where the patients are not helped by the current therapies. And all of the studies that you've heard represent progress in some form or another, either incremental progress or potentially quite substantial progress in a couple of cases, and in different ways. In some agents, you know, very narrowly targeted therapies, other agents or other approaches using combinations of agents in new ways to try to move the bar forward. And these are six of the most exciting, most interesting presentations in the leukemia space at this meeting. They're by far not the only. There's many other studies as well that are helping us understand the biology and treatment of these diseases. At this time, we'd like to take questions. We'll take questions from the floor first before going to the phones. Please begin your question just by stating your name and affiliation and to whom the question is directed.
Nick Mulcahy from Medscape. Question actually for you, Dr. Steensma. Dr. Ravandi just concluded by saying that, in his opinion, his study reflects a new option for salvage therapy in this patient population, the AML older patient. Do you agree with that?
I think it's difficult to know just where this drug is going to fit. I think the benefit is clearly statistically significant, and the patients who got the combination therapy overall did do better, particularly those who were over age 60. I think one of the slightly discouraging things, and I'll invite Dr. Ravandi to give his perspective as well, is that the magnitude of the benefit was not great. You know, we would have loved to have seen, you know, a 5-month or an 8-month improvement in overall survival. We didn't see that. Often progress is incremental like that, however, and not a great leap forward. So, Dr. Ravandi, if you want to expand on that, that would be wonderful.
I actually like to think of AML as being equivalent to metastatic cancer. Patients with AML present with disease all over the body right from day one, and obviously in relapsed AML. And in solid tumors, we are excited about 1 or 2 month survival improvement. And I don't see why we shouldn't be excited in AML as well. I think another thing is that in AML, we probably have set the bar a bit higher for ourselves because we do cure about 40% of patients with AML. And again, if you consider it as equivalent with metastatic cancer or metastatic lung cancer or breast cancer, you don't see 40% cure rate in metastatic lung cancer. So I think our expectations for AML is much higher than the expectations are for solid tumors. And again, to me, this improvement is highly significant. And as Dr. Steensma mentioned, we are all excited about leaps in drug development. You know, we were all got extremely excited about TKIs in CML. But as you all know, these leaps happen only every once in a while, and we should not discount the small steps forward in treating our patients and providing them better treatment options.
Hi, I'm Neil Osterweil with Frontline Medical News. A question first for Dr. Stock. You mentioned that, you know, it was 14 years ago at this meeting when you first, you know, reported these data, or these data were first reported. What took so long?
Well, that's a very good question. Those were retrospective data. We looked back, and then it takes a number of years to get a new trial to move forward. We planned that very carefully, and in the U.S. intergroup, we began plans once the data were validated in other countries. We began plans to design a study. But it takes a number of years for those things to get activated, and I wish we had gotten it done faster. It would be lovely to move quicker, and I think it's crucial to do so. We did have every intent to start a little bit sooner. There were some slowdowns initially due to the fact that we were modeling our protocol on a pediatric protocol, and just at the time we were about to activate our study, there were some changes in the pediatric protocol, and thus we had to go back and change our protocol to coincide with those. So there was about a year lag there for that particular change. But we had every intent of moving forward. The trial took 5 years to actually do, and it would, I can only say that I wish very strongly that we would move forward more quickly.
One other question about that too, please, about your age cutoff of 40.
Yes.
Do you think it could be extended further into age range, and how far?
That's a really good question. So, and that's sort of the question of the day amongst all of us. The young adult population is somewhat artificially defined. It's been defined by the National Cancer Institute as being that age range, and we based our trial on that age range in part because we had retrospective data showing similar results for the 16 to 20-year-olds and the 20 to 40-year-olds. The question whether the drug combination could be applied to older adults has been somewhat explored in some of the other studies that I mentioned. It becomes more toxic because of some of the drugs that we really try to intensify in this regimen. But the question, I think, for the future is, can we use this regimen with slight modifications of some of the more toxic drugs? And I believe the answer will be yes. And I think that we will learn now we have some tools to be able to begin to understand some of the toxicities better and make adjustments early on for those toxicities, potential toxicities, to avoid them. So I hope that the answer will be yes, and I think it probably will be.
And I'll just very quickly add, this is not the first foray into a pediatric-like regimen for younger adults and older adolescents. Wendy Stock was quite influential in a protocol that Dan D'Angelo first proposed in 2001 based on her data using a children's hospital regimen in young adults that has been published several years ago. So smaller consortia and such have already for a number of years, based on Dr. Stock's data, started moving the bar forward here. But this is a cooperative group trial, and these, of course, take more time to open and to accrue.
Dr. Steensma, Alice Goodman with the ASCO Post. Dr. Steensma, so would you consider, which of the studies that we heard today would you consider the larger rather than incremental progress, big progress? And why? And could you elaborate on that?
Yeah, so putting me on the spot about that.
That's what we want to do.
No, it really would be unfair because all of these are important. My gut reaction is to say that the IDH2 inhibitor is the most novel in terms of a different way of approaching leukemia. That being said, each of these is important for a specific patient or group of patients, and so I don't want to in any way discount any of the other studies. But the IDH2 is a novel mechanism of action. It's a narrowly targeted therapy, but these are all important studies in their own way.
Well, not to discount their importance, but we have to understand this in the context of how to report about it. So it isn't to diminish it.
Absolutely, absolutely.
So which would you?
We can talk about that offline.
Janine Benning, Medical Facts. I have a question for Dr. Stock. Did you see any differences between here? Did you see any differences between boys and girls, female or male?
That's a good question. There were no differences between males or females. There were no differences in precursor B or precursor T ALL, and there were no differences by age. So the 16 to 20-year-olds and the 30 to 39-year-olds did as well in terms of statistical significance.
Yeah, hi, Adam Forrestein with The Street. Dr. Ravandi, and I guess Dr. Steensma too, the Valor study failed. So you guys talking about a statistically significant survival benefit, but the study failed. So I'm trying to reconcile that with your comments.
I'll let you go first with that one.
This was a positive study. You do show, if you think about the population of patients, 451 were older AML patients. And among them, there was a statistically significant p-value for survival advantage using the vosoruxin arm of the study. If you look at the entire population, if you're fixated on the p of 0.06, there is the stratified log rank analysis that takes into account the stratification, and that p-value is 0.02. So in my opinion, this was a positive study.
What about the, there was an interim analysis where you added, I think you added like something like 270 odd patients. So how do you account for that in the statistics?
Okay. So again, one of the things that makes me very proud to have been associated with the study was that the design was extremely well thought of among all the investigators. So every analysis you saw on that slide set was pre-planned and pre-specified. So essentially, this is you have to remember, AML is a small population overall in terms of cancer population. It's very easy for breast cancer doctors and lung cancer doctors to every few years every couple of years come up with a 1,000-patient study. So in the relapse AML, as you heard, this is the largest study that I am aware of, and I might be wrong, but to date that has been conducted. It included 124 centers among many different countries. So to conduct an AML study, it's definitely much more difficult. And the other problem that the lung cancer or breast cancer physicians don't have to deal with is allogeneic stem cell transplant. There is a significant post-treatment strategy that modifies whatever you do. So in terms of what you said, the design was that you look at initially a certain number of events, and then if you clearly see this study is not going to get you anywhere, you shut it down. Why would you want to essentially put a whole bunch of other patients through the study? If you clearly see that it is positive, you go ahead and close the study and say, but if there is an area that you actually, if you increase the population, you clearly will be better off in terms of determining if the p-value or the statistical data is solid, you would allow it to expand. But again, this was predefined, and the increase was also pre-specified. The 225 patients that were added, it wasn't that somebody just said, well, let's just do 225.
You did all that, and then you got a tiny benefit. I mean, Dr. Steensma says, the benefit.
I mean, again, your opinion about tiny benefit is, again, and that's Dr. Steensma, well, I didn't think he called it tiny, but.
Well, so I think, the relapsed refractory AML is a really, really difficult population, no question about it. But there's also no question, 7.5 months is pretty crummy, and we need to do better than that. So yes, this is, the curves separate, but I think, we obviously need to keep working.